Good morning to everyone, and we are so very glad that you're here today. My name is Carol Hollins, and I am the NAMI San Antonio Education Program Coordinator, and just for today, I am your moderator. We're going to get started immediately because we have such a power-packed program to offer you today, with everything being centered around advocacy for Children's Mental Health Month during the month of May. I'd like to cover a couple of housekeeping items, first of all. Everyone joining us today, please do us a favor and enter at least your first name and your zip code in the chat box. If you're using a personal computer, just hover over your screen, your Zoom screen, and click on the chat icon. It's located down at the bottom, about center of the page, and then enter your information and then hit enter. If you are using a mobile device, tap your phone screen. There should be 3 little dots that show up, and then tap chat, tap the dots, then tap chat, type in your name and zip code and hit enter. We'd appreciate that very much. That way we will keep track of everyone that was here. Okay, next slide. Today's agenda is going to include words of welcome from our very own board president in just a moment, Doug Beach. And then we're going to cover a few upcoming events for you. Jackie Dickey is going to introduce all of our fine panelists today. We will hear from the presenters, and then know that at the very end, we're going to hope to have enough time to cover questions and answers. So if you have a question for anyone today, please put that question in the chat box. We have someone monitoring that throughout the presentation today, but we're not going to make an attempt to answer questions until everyone is finished, because we have 4 different presenters today, presenting organizations today, and we want to make sure that we give everyone adequate time to cover what they need to, and then we'll close. And with that, I'd like to introduce our board president, Doug Beach, President, NAMI San Antonio, our pride and joy.
Well, thank you, Carol. It's good to be on the call this morning, and I'm looking forward to, at some point, being back in person down the road. I miss seeing everybody. We have a wonderful program. This is, as everybody knows, this is Mental Health Awareness Month. Not only are we going to be talking about children's mental health today, but there's probably more going on in our community to improve access to care than at any time that I can remember in the last 20 years. And it's amazing that this is all coming together in spite of the pandemic and social distancing. So it's good to see everybody virtually today. And Carol, thank you, and to all the staff for putting together a great program.
You are quite welcome, Doug. Once again, please don't forget, enter your name and your zip code in the chat box. You will make our very own Laurie Packard very happy, who is our attendance tracker. And now I'd like to introduce another favorite person to you this morning. Her name is Jackie Dickey. And Jackie has words of wisdom to offer about a brand new volunteer program that we're introducing for NAMI San Antonio. And with that, Jackie.
Thank you so much, Carol. I've been a NAMI member and a volunteer for 16 years. Over that time, I've seen NAMI make many additions and transitions in services that it provides in an effort to more fully support advocacy for mental health. NAMI San Antonio has recently made one change that I've joined. It was to develop a volunteer committee, and I'd like to introduce the members of that committee now. They are Lori Packard, Katie Martin, Carol Hollins, and Ed Dickey. Our goal is to coordinate the introduction of volunteers into our local affiliate. As requests for information are received, we plan to contact the interested parties, interview them to find out their abilities and interests, and then match them with NAMI San Antonio's needs. And also we'll maintain some contact information on their preferences, so each volunteer, so that as recurring needs come forward, we really have a bank of interested people to call. Besides education and support leaders, we are now needing people whose skills are behind the scenes to support our virtual groups and online presence. Some people call it IT, programming, or web design, but whatever level of clinical or technical experience you have, you would certainly be welcome into our volunteer program. We hope to be able to better connect with our families and more broadly support our community. So how do you get started in being one of our valued helpers? As the slide explains, we have our phone number listed with the option of extension 101, so you can leave a message for us to call back. The email listed will get your message to our committee so that we can return an email to you and set up a contact. And the website at nami-sat.org will show a white band at the top with Get Involved as one of the options. Clicking on that will turn the letters orange and open a menu like the one on the screen, and choosing volunteer will open a form for you to fill out that will be sent to our office so our committee can make a contact with you. And by the way, choosing to be a member is another great choice if you can't commit time right now. And membership is open at 3 different cost levels, but you still get the same benefits. And that makes a statement to your community that you support the largest grassroots organization dedicated to improving the lives of persons living with serious mental illness and supporting family members and others who care. Thank you.
And Jackie, you may continue.
Oh, okay. Well, I have a wonderful opportunity today to make the introductions of our panel. We are honored to host a varied panel of experts that serve our children in different capacities. The NAMI Basics program that we offer here in San Antonio is designed for parents and other family caregivers of children and adolescents with emotional and behavioral disorders. As our basics information says, in NAMI, we focus on the challenges that the various conditions create. Those emotional and behavioral challenges are extremely similar across all mental illness diagnoses. We believe that families can find support from each other as they learn to navigate those challenges with their children, regardless of what the diagnosis is. So again, let me introduce our panel. We begin with Melissa Tijerina, who is the Children's Services Director at the Center for Healthcare Services. We have Dr. Jeannie von Stultz, who is the Deputy Chief at Mental Health Services, Bexar County Juvenile Probation Department. Rebecca Helterbrand is the Executive Vice President at the Center for Young Minds. Angela Pao-Johnson is a board-certified behavior analyst and CEO of the Autism Learning Collaborative. With her is Sydney Barton, who is also a board-certified behavioral analyst, and Dr. Jason Hurst, Clinical Director of the Autism Learning Collaborative in Dallas. Our panel.
So good morning, everyone. I am excited to be talking with you today, and certainly during the month of May, when we recognize children's mental health and the issues that go on in every month of the year. I was asked to talk a little bit about children's mental health and what that's looked like during the pandemic. So if you'll go to the next slide. You know, I think it's important for us to keep in mind that 13 to 20% of children and adolescents have a diagnosable mental, emotional, or behavioral disorder. And about 10% of those individuals have a serious illness. And children's mental health is so important because we know of all mental illnesses, 50% of those illnesses start to have symptoms by the time someone's 14 years old and 75% by the time someone's 24. So our children's mental health efforts are extremely important. We want to, as with any illness, start to provide services and intervention as soon as possible so that we have the best possible outcomes for an individual. About half, a little more than half of our children who have a diagnosable mental illness do not receive services or treatment. And so that continues to be a real challenge. So when we talk about the pandemic, it was March of 2020 when Texas had their first individual who tested positive for COVID-19 outside of those individuals who were here for quarantine. And on March the 14th, Governor Abbott issued his emergency declaration. And in conjunction with the Texas Medical Board and the Department of State Health Services, we started to put into place how we could continue to safely provide services to the individuals who needed to participate ongoingly or be initiated into services. And so we were allowed to do that through the use of telehealth by either video or telephone. And for us at the Center for Healthcare Services, that has we've continued to see some people in person as well as those through telehealth options. It's been a change of about 40% being seen face-to-face, and the others have opted to be seen through either video or telephone. So when we talk about the impact on children, the CDC has statistics that show us that mental health needs have increased during the pandemic, not just for those who are already in services, but for our population in general, not surprisingly. For individuals, we've had an increase in individuals who are thinking about suicide. That rate has doubled. And certainly in our community, we have been working very hard to try and address suicide prevention and intervention. And so this is certainly something that impacts the work that we're doing. We know that folks are finding themselves in situations that pose danger to them more often as a result of the pandemic. The symptoms of anxiety have increased across the country during the time of the pandemic. For anxiety, it's increased to 33.4% from just over 8%. And symptoms of depression have also increased up to 27% from what was 6 to 6% prior to the pandemic. And ER visits for children have also increased during the pandemic. For children that were ages 5 to 11, from the beginning of the pandemic until October of last year, there was an increase in 24% for ER visits for children in that earlier age. And for children 12 to 17, that increase was 31%. So we are certainly seeing in lots of different ways the impact the pandemic is having on overall mental health and the impact it's having on those who are already working with mental health challenges. So there have been a lot of studies done across the country. These are longitudinal studies that were already in place, not just in our country, but across the world, because the pandemic has been a worldwide event. And so it's interesting to see that the things that are happening in our country are happening in other places as well. There was a German study that really looked at children's mental health. They compared this to prior years. And what they found was that there was a significant decrease in the health-related quality that children and adolescents were experiencing during the pandemic, a change from 15% to 40%. There were more mental health problems being identified. It almost doubled in the percentage that were identifying those issues. And again, those higher levels of anxiety that the CDC was reporting as well, where we have folks having a pre-pandemic percentage of 14.9 in that country going to 24%. They also found in Germany, as we have seen some here locally, that those with lower socioeconomic status also had more struggles. That if they were living in a limited space situation, the impact on the pandemic and on quarantine was more impactful to them. In Australia, they also looked at pre-pandemic and post-pandemic with children. They focused on looking at adolescents, and what they found again were significant increases in depressive symptoms and anxiety symptoms, as well as among young girls, a particularly significant decrease in life satisfaction. They also noted that there were learning difficulties, that folks had an increased conflict with parents, that there was feeling less socially connected during the quarantine and during the lockdown measures. There were some studies that showed that some of the children's anxiety was around what they were missing out on, that they were less fearful of having COVID than they were of what they were missing in regards to being at school and being around their peers. And for those in the high school level, those opportunities that really are once in a lifetime that you experience in your adolescent years, proms and graduations and dances and all of those types of things. So the impact has been significant for our young people. In China, they found that for individuals that were left without a companion during the weekdays, that they tended to have higher depression and anxiety as well. So what is the impact? You know, we don't live alone. We live with our families. We live with others around us. And certainly the pandemic doesn't impact just the child themselves. It impacts the entire family and the household. So everyone within a household was experiencing isolation. And I always like to think that children are at their best when parents are at their best. And so we had entire households that were being impacted by changes in their income, in their working style, whether they had a job. So there was certainly a lot more stress within households, and that has an impact on the well-being overall. We saw an increase in unemployment, folks who were no longer able to work. We also have seen more domestic violence and more incidents of child abuse and neglect. The pandemic has also put people in roles that they were not traditionally in. We have parents who may have been involved in their child's education, but they were all of a sudden taking more of a lead in making sure that education was happening for their children, that learning was happening. Mm-hmm. And I don't know about you, but oh, can you hear me?
Yes, now we can.
Oh, sorry. And so also there has been increased disadvantages, like we saw in some of those studies around the world, that individuals who were already in at-risk categories or were disadvantaged, whether they were living in crowded households, whether they already had issues around food insecurity, the resources that they need, that those were just amplified during the pandemic. The digital divide was a huge issue because even if you have opportunities to participate in school, in treatment services through telehealth, you still need to be able to have cell phones to deliver that, computers, access to the internet. And so these were certainly challenges that we saw our families dealing with. The school closures not only impacted education, but a lot of our children receive mental health services in the school settings. A lot of our children rely on the school for everyday needs. A lot of food insecurity is addressed by the school districts. Also the safety net for children who are not safe in their homes. The schools have historically been that safety net where they're able to report those concerns to child welfare, to other entities who can intervene. And so it wasn't just the loss of this educational needs, but it was also a safety net that really helped to keep our children protected and safe. And certainly we receive a vast number of majorities from the school district where they identify children with behavioral health and mental health needs. And so this avenue for people to get to services and to treatment was severely compromised during the pandemic and has been. And when we look about the impact on services, so as those individuals delivering service, we had to really quickly align and figure out how do we engage individuals in this new model. If folks are able to participate over the phone or through the video conferencing, what does that look like? And what we found again was there were some folks who didn't have the resources they needed. In our early childhood services, we purchased a number of cell phones that we were able to issue out to families so they would have the electronic devices needed to be able to engage in those services. There were issues around engagement. Children who were used to talking to counselors in person, all of a sudden were doing it from their home, where there's lots of different distractions that come into play. When everyone's at home, there may not be a good place for someone to go for that individualized service. So there were lots of competing things happening in the environment, as well as privacy issues. If a child is needing to talk about things that they don't want a sibling, a parent, someone else to be able to hear, when those services are delivered in the home, that becomes more difficult. We certainly also found that engaging for the duration, a service time that would typically be an hour, it started to be a struggle to engage at that level, especially with our younger kids. And if they were doing it by phone, even more so. It's hard to keep a child engaged over the telephone for an hour, especially if it's a topic that they are not necessarily interested in discussing in that moment. And our workforce themselves were also, just like parents were being impacted by the pandemic, our workforce was also being impacted. And so as we go back to the new normal, as we transition, especially this fall with kids going back to more traditional type of school environments, we're going to need to work collaboratively as a community. We're going to need to work with other social service agencies, supporting our schools and their campuses, and continuing to support our families, because it's going to be different and it's going to be challenging for folks returning to school. Resiliency and increasing protective factors within our families is more important than ever. And being patient with others as people reestablish what education looks like, what treatment looks like. And then we need to make sure that we have enough non-academic supports in place to help families with the food, with the other needs that they have that are basic needs, so that the schools can focus on getting kids back on track with their learning, and then also continue to reinstate that safety net for kids. So there may be new hybrid models of service where we may be able to continue to do some things through telehealth, but go back to more face-to-face services. And so certainly the next slide, the Center for Healthcare Services continues to be available. Our crisis hotline is available for individuals experiencing crisis, and this is open to anyone, whether they're in our services or not. If they're in Bexar County experiencing a crisis, they can call that 223-7233 number, and our enrollment number is also there for children and adolescents who find themselves needing mental health services. Thank you.
Well, and then that leads to me. I really appreciate the opportunity NAMI is giving me to speak about juvenile justice issues. I know that oftentimes our population is viewed as kind of viewed in a different way. And so I really appreciate the opportunity to talk about behavioral health issues with juvenile justice and just help families understand kind of some questions that they may have related to juvenile justice involvement. So like Melissa was talking about, what we have seen, interestingly, is actually a decrease in the overall, what we call offense rates or crime rates among the juvenile justice population during COVID. But what we have seen, unfortunately, is while the amount of crime has notably decreased overall, we have seen an uptick in regards to family violence cases related to juvenile justice involvement. Next slide, please. So what I wanted to kind of start off with is just talking about kind of the prevalence of children that present with behavioral health issues in the justice system. What we see on average is that about 30 to 50% of youth in our system present with a significant behavioral health issue. And what I mean by significant is oftentimes it's mood disorders, beginning stages of psychosis, early onset of kind of significant mental health conditions. One thing I would like to kind of really emphasize, though, is while we have a pretty significant percentage of youth that have mental health issues, it doesn't necessarily mean that all youth that have behavioral health conditions wind up in the system. While 30 to 50% of our youth have mental health conditions, it's not the 1 in 5, right? So the majority of children with behavioral health problems are doing well, and that's often because of the fact that they have caregivers that are aware of their condition. They have caregivers that are ensuring that their youth get effective treatment. And they have caregivers that are really creating a safety net of support for their children. What tends to wind up in our system are children that, because of their behavioral health conditions, struggle with aggression or struggle with substance use. But know that the far majority of the 1 in 5 children that struggle with a mental health condition aren't in our system. Next slide, please. What the purpose of our system is, yes, we want to ensure the safety of the community. We want to ensure accountability. But the reason that the juvenile justice system is separate from the adult system is we want to focus on habilitation. And I won't even say rehabilitation, because oftentimes it's not that someone's relearning or a skill, it's learning a skill. And so we, as a system, concentrate on children who struggle or who present as moderate to high risk to reoffend. And I'll talk more about that in a second. And what we try to do is for children that are low risk to reoffend, low risk to commit an offense, there are many diversion efforts in place to kind of make sure those kids don't get further in our system. And a couple of those diversion opportunities are first responders, police departments. There are diversion programs within schools. There are diversion programs within our system called specialty courts. And then there's also what we call specialized caseloads. And I can kind of go into detail about each of those. In regards to the first responders, what we know is that for children who present with significant behavioral health issues that are what we deemed low risk to reoffend, law enforcement has worked really hard, and not only in Bexar County, but across the state and across the country, to recognize when a child is having a crisis. You will hear of trainings called crisis intervention training. Here in Bexar County, we have something even called Children's Crisis Intervention Training. And what we do in those trainings is to help first responders, law enforcement, fire, recognize when a child is having a behavioral health crisis. And when they arrive at the scene, being able to work to de-escalate that crisis so that the child doesn't get perhaps assaulting the officer or damaging property. And instead of bringing that youth who's having the crisis to a juvenile detention center, instead connecting that youth and their caregiver to either crisis services such as a psychiatric hospital or outpatient services in the community. Schools are often doing things like first responder programs within schools where there may be a specialized team that responds to that child's mental health issues when they're in crisis. So again, it doesn't escalate to where law enforcement is even called or where they're brought to the detention center. And we're seeing more and more in schools, there being early screening for mental health issues through outside partners and connecting those children with the support of their caregiver to appropriate outpatient services. We have in our system for first-time offenders opportunities called specialty courts, and that's kind of a unique trend across the country where instead of the child just going before a judge when they get in trouble, the judge regularly monitors the child's progress in treatment and regularly ensures that the child is following kind of the agreed upon requirements of the court. And as a child progresses in treatment and begins to engage in school and in pro-social activities, the court incentivizes those activities. They may sanction if a child is struggling and give them kind of natural consequences if they're struggling. But the idea is to divert that child from becoming further involved in the system. And then we also have within our system what we call specialized caseloads. We have officers, probation officers that are trained in understanding behavioral health conditions, whether that's mental health or substance use conditions, and recognizing that the road to recovery is not a linear one, that it's an up and down process, that it requires understanding the mental health condition, knowing cycles in regards to substance use and, in regards to a mood disorder, and providing support to the youth and the family in those times. You can go on to the next slide. So what we often see from families is an intensity of response when a child's first referred to the system. First and foremost, we see a lot of families that are incredibly afraid when their child is first referred to the system, especially if they're detained. The family's concerned about the child's safety. The family's concerned about the child's future now that they have this crime on their record. But we also see sometimes families that are incredibly angry, and they may be angry at the system, whether it's the law enforcement system, the school system, but the families also may be incredibly angry at the child or youth themselves. And that's often because that child or youth may have injured other family members, may have destroyed property within the home, or it may just be this long journey where the child has persistently gotten in trouble. And so at this point, the families are incredibly frustrated. We do see at times families that are also pretty detached when the child gets involved in the system. And that's normally because families feel really overwhelmed just with how complex the system is, and oftentimes pretty exhausted because it's typically been a long journey before the child winds up involved in the justice system. And sometimes we see families that are relieved that their child's been referred to the justice system. And in some ways the relief is because, now they feel like their child might be safe. If they're locked in the detention center, they know someone's watching the child 24/7. And the family may feel that help is on the way. Like, finally, now my child is going to get services. And I would like to kind of expand on that. So let's kind of move on to the next slide. So when it comes to the justice system, what I want to kind of emphasize is that the justice system, what we're focused on is criminal behavior, right? That's kind of our role within the community. And what we do when a child is referred to the system is that we want to assess the child's risk to reoffend, the child's risk to commit another crime. And there are a lot of factors that go into play in that, but we're really focused on in providing support and intervening with those youth that are moderate to high risk to reoffend. What we often see, though, is that children with behavioral health conditions, they're really not criminal, right? They are what we would deem a low risk to reoffend. And so bringing them into the system, as much as a family would hope that that means that child is going to get support, just the mere labeling of a child as a juvenile probation child can increase a low risk child's risk to reoffend. Just the mere start of, it's being around other youth that are more criminogenic, being around youth that can teach that child, the behavioral health child, more kind of criminal-like behavior, actually places that child at increased risk. So next slide, please. So what we really encourage families to do is, if you do have a child that's in our system, from the very get-go, we encourage the families to try to be as communicative as possible. When law enforcement or that first responder arrives on the call for whatever incident led to that call to the police, please advise law enforcement immediately that your child has behavioral health issues, and also tell them what helps calm the child down, what oftentimes can trigger them to escalate their behavior. When a child goes to court, please inform the defense attorney of all your child's kind of behavioral health needs, because that defense attorney can advocate for your child in regards to what services would be helpful. If your child is brought to detention, we ask that you please ensure that the medication provided to detention, and that detention is informed of all kind of behavioral health conditions and things that can trigger behavior or things that can support them. And then if a child is on any kind of supervision with our department, whether it's deferred prosecution or probation, we ask that you try to work with that probation officer. Our goal is to rehabilitate that child. So the more that we know, the more that we're informed, not just at the onset, but on a daily basis. If they're struggling, if they're doing well, that can help us help you navigate the system. Because it's really about not just that child in regards to intervening. What we know is that child's going to be off probation soon, and it really has to be that child's whole world being involved in their habilitation. And like I said, I have my email at the beginning of this. I'm more than happy to answer any questions, either at the end or via email. Thank you for your time.
Hello, everyone. On the next slide, we'll get this process started for the Center for Young Minds. We are so honored to be a part of this panel discussion today. We are nestled within the Ecumenical Center here in San Antonio, and we are graciously funded by the Kronkowski Charitable Foundation. So if you'll advance the slide and to the next one, we are actually what's called a collective impact model. And so on the next slide, this gives some outlines of what we mean by collective impact. And this first was cited in the Stanford Social Innovation Review, well over a decade ago. It's had a lot of evaluation work. It's a really proven model that goes well beyond collaboration in communities. So these slides are going to be provided to you after this meeting, and my contact information is available in case you'd like additional details on collective impact models, but we're going to dive into what this group is doing. So on the next slide, let's talk about the mission and work ahead for Center for Young Minds. So our mission on the next slide, you can read it. And as you read it, I want to point out a few thoughts here. First, as early as possible is included in this, and community developed this mission statement. In fact, everything I'm going to show you today was developed by community. Early as possible for us means that we're not focused on psychiatric crisis beds. We're not focused on law enforcement touches. We are focused on ways to get to our young people well before the crisis ever starts. So very upstream approaches. And it was very deliberate that it doesn't say effective and responsive treatment. It's not that we aren't looking at medical models. We are looking at services that may go well beyond the medical model that are evidence-based. So on the next slide, the community came together and they decided where we wanted to focus. And so the slides presented earlier by Melissa and Jeannie really play into this information. And so, for example, this won't be surprising to anyone here, but 1 in 5 youth will have a mental health need, mental, emotional, or behavioral. And so that was a problem that our group really wanted to focus upon. And then the majority of children and youth are not getting treatment. Melissa said that earlier. But when they do get treatment, the national statistics say that that average wait is somewhere between 8 and 10 years. And because this is a behavioral health initiative and not just mental health, we are looking at substance use. And the stats on the average age of first substance use in Bexar County is 13. So as community came together and picked these problems to focus on and develop the mission statement, they also came together in the next slide through community input sessions. Many of you participating today have been involved in this effort. These were large virtual sessions held in November and December of last year. NAMI was well represented. Some of our panelists were represented on this effort. And the idea was, how do we take data indicators, factors, strategies, how do we come up with the plans to address this upstream work? And we're very pleased to share that nearly 90 individuals representing 45 organizations participated in this community-driven process. And I won't go through all the stats, just suffice it to say that people actually enjoyed the process, even though it was a virtual effort, which we were worried would be very difficult for people to participate in, but they got the hang of it, and they really gave lots of good feedback. So on the next slide, data, factors, strategies, oh my. They came up with 5 data indicators with 18 factors and over 70 strategies. And that was a lot to absorb. So we needed to put some governance around this process to see, of those 70 plus strategies, where do we start? And so on the next slide, you'll see, if you'll click once, you'll see our governance structure. So we are guided by an amazing, incredible set of young people. They're aged 13 to 18. They really tell us the work ahead and they help guide that work. They're becoming educated, informed, activated, and they have a seat on our steering committee. And for some reason, my slide isn't showing all the perspectives around the steering committee, but there's faith, there's education, there's just all these different perspectives that are definitely playing a role in this process. So it's city, county, philanthropy, substance use, clinical, the family itself, nonprofits, education, and youth that are all playing a role. They decide what we work on, community does, and our young people with a seat at the steering committee table. So now what they've done in our last meeting, they decided what work groups we would start planning for. And so what they decided were data. So I'm pleased to share with you that Dr. Jeannie von Stultz is co-leader of our data work group. She just met this morning with some folks, and they are working on the data indicators and helping us to use data-informed decision-making. We're also looking at integrated school supports. No surprise there. We're looking at education and prevention as another work group. No surprise there. Peer supports, because you all know, being a part of NAMI, how important peers are to this process. And it's an evidence-based tool. So peer supports, both formal and informal. And then mapping our assets and publicizing the resources. And then updates on policy and trauma-informed care. So on the next slide, what I want to tell you about is the youth study that really kicked off our youth council. So I said earlier that we're guided by young people, we're guided by the seat that they have on our steering committee. Community is deciding what happens next, but they are also informed by a study that was done right here in Bexar County. So on the next slide, this study was done in collaboration with over a dozen nonprofits that have trusted relationships with young people. We leaned into those trusted relationships and offered virtual guided discussions with small groups of similar age youth. In one case, we were able to go on site to a nonprofit, Girls Inc., and have socially distanced discussions. And we did have a clinician present for all sessions because of the subject matter. However, I'm very pleased to share with you, we never had to utilize the services of that clinician. And so on the next slide, our participants really came from a broad cross-section representing the rich cultural diversity of our amazing community, whether it was their age, whether it was their ethnicity, whether it was their geographic positioning. And we did have so many young people from the East Side, West Side, and South Side participating, deep areas of inequity that we know need to be targeted in our community. So on the next slide, we did a follow-up survey with everyone who participated, and no surprise here, because Melissa gave stats earlier, our young people did report a decline in their mental health from pre-pandemic to the time of the study. And the time of the study was between the September and November of last year timeframe. Now, the median drop was 10 points, but we also know that if you pull out the young people who declared a drop, and not the ones that said, I'm fine, or the one person who said their mental health had actually improved during the pandemic, then you start to discover that the decline was actually 15 points. So on the next slide, we had 14 sessions with a total of 40 young people. And what we did in this qualitative review, and I'm going to drop into the chat a link to the full study when I'm done, is we aggregated the common themes that we were hearing over and over and over again. And the number one thing that our young people said, and it's not surprising based on brain development and research, is that our young people want to be in settings with their peers. They want a casual setting. They want a sense of connection. And none of this is going to be surprising for those of you that work with young people, but they said it loud and clear. This is what they need and want. The next thing they asked or told us about was many actually reported great relationships with at least one adult in their life. However, when an adult got it wrong, it was very dramatic for the young person. The young person did not feel seen, heard, or validated. And so the encouragement for adults working with young people or with young people in their lives, make sure you're listening, make sure you're validating the young person's experience. The next thing that young people said was many of them are already embracing really strong coping mechanisms and building their resiliency, but they're seeking more. And they cautioned, no surprise again, that it be person-centered, that you not create a music program and expect everyone to be interested. Create a wide array of ways for young people to gain new coping skills and approach them with those. The next item they had was that most youth recognize, and this was said earlier again in our panel discussion, our schools are a very important part of the system of care. Our young people expect that those services and those supports and those resiliency building efforts are in their schools, but they're also incredibly smart enough to know that they might be under-resourced. So resources could be people, could be training, it could be dollars, it could be many things. And the final thing that we heard from our young people is that they're not desiring a clinical setting. And back in February, we hosted a webinar specifically targeting clinicians because we knew this information could be slightly distressful for those of you providing clinical services, but there's so many things that clinical teams can do to create a warm, welcoming environment for our young people. So on the next slide, this is just a snapshot of the many, many quotes that are organized in this study that I'm going to drop a link into for the chat box. So we've changed the first name of the young person to protect their anonymity, but the ages are the age of the person that participated. And so, for example, Aaron wants to take charge of his own mental health. He just needs education. He wants to reduce the stigma and manage his own health process. Lily, age 11, just really wants to be in a club where she feels like she has friends and she isn't an outcast. Madeline coaches us strongly at age 18 that youth have plenty of authority figures, really just need someone to trust and talk to. And then finally, Rory, who is actually in college, but she said that the only way she made it through high school was as a freshman and a new person at that school that had no friends. The school counselor put together a new students group, and that's how she excelled through high school. So this is just a sampling of the many, many, many comments that are in this study. I'm going to be dropping this into the chat box. And on the next slide, here's my contact information. I welcome any questions after this presentation or throughout the months. We look forward to delivering upon the promise that we have with our community in terms of our mission. Thank you.
Hi, everyone. My name is Dr. Jason Hurst, and I am the Clinical Director for Autism Learning Collaborative in Dallas. I'm joined by our CEO, Angela, and our Clinical Director for San Antonio, Sydney. And we're really grateful to have been invited to this conference to help shed a little bit of light on a topic that doesn't traditionally fit into the mental illness category. We're here to talk about the developmental disorder of autism. And if you could just go to the next slide there. All right, great. So again, we're here to shed some light on autism as a developmental disorder. And we want to talk about what it is and what it isn't, and what can be done to support the rapidly growing number of individuals living somewhere on this spectrum. So let's start with what autism is. Autism is a pervasive developmental disorder, and there are really only two characteristics that actually define autism, and those are deficits in social communication and interactions, and the presence of repetitive or restricted patterns of behavior and interests. Of course, these two core dimensions must also be present to a sufficient degree as to impact daily functioning, and no other diagnosis should provide a better explanation of the symptoms, as is the case with any diagnostic category in the DSM. Some common issues experienced by individuals with autism include a lack of eye contact with others, delayed or different speech, difficulty understanding others' perspectives, and a reduced or absent interest in interacting with others socially. Usually observed as social awkwardness, a lack of skill in navigating social situations, or something similar. In addition, individuals with autism may have different sensitivities or reactions to sounds, lights, or physical touch, and they may engage in repetitive body movements or vocalizations and struggle with changes to routine or expectation. That being said, autism can manifest in a vast variety of ways, and no two individuals with autism experience exactly the same combination of those two core characteristics. What I usually like to say is there are as many variations on autism as there are individuals with autism. So not all individuals with autism have a learning disability, a speech delay, gastrointestinal sensitivities to gluten or casein. And despite the sort of popularization of the savant syndrome associated with autism by the movie Rain Man, most children with autism do not have savant-like abilities. But on the contrary, most individuals with autism also don't actually have an intellectual disability. So this is a developmental and not an intellectual disability. And most of them fall within the normal range on the IQ scale. Really, having autism only means that an individual has difficulty with social interactions and has different interests and responses to their environment. Next slide, please. So looking at some facts and figures, currently, as of the data in 2018, which are lagging by about 4 years, the number of individuals in the United States diagnosed with autism was about 1 in 58. This is drastically higher than previous incidence rates from even 50 or so years ago, where it was 1 in the hundreds. And this has led to people calling the increase in incidence for autism an epidemic. And there are some different explanations for why there are so many more people with autism today compared to the last few decades. For one, autism was recently, as of the DSM-5, rolled into a spectrum disorder along with similar disorders such as Asperger's and pervasive developmental disorder not otherwise specified. So to some degree, we have multiple disorders being rolled into one spectrum disorder, so that contributes to the increase in incidence. We have a much greater degree of awareness and sensitivity to the presence of autism symptoms. And we have much better access today compared to previously to high quality healthcare and diagnostic care. So we're simply much more likely to catch symptoms of autism because people have become so much more aware of autism thanks to the work of our strong advocacy bodies such as yourself and also Autism Speaks. Some interesting other facts: autism is 4 times more likely in boys compared to girls. The symptoms also emerge at or after 18 months of age. And they're sort of the onset at 18 months of age is part of some of the misconceptions about causes for autism, because right at that 18 months of age tends to be where there are a lot of vaccinations scheduled. So parents will often take their children in to get vaccinated and then start to see these symptoms emerging shortly after. And unfortunately, that correlation does not actually equal causation, as we all say in the scientific community. We actually don't know what causes autism. We know that it's not vaccines. We know that it's not exposure to gluten or casein unless the individual actually has a biological sensitivity to those substances. And there are likely multiple possible causes. In fact, autism is probably not even a singular issue, but rather a group of possibly thousands of developmental problems that can be triggered through genetics, epigenetics, or environmental triggers that each result in a similar developmental difference. So again, there are just as many variations on autism as there are individuals with autism. Because we don't know what causes autism, we also can't ever say that autism has been cured, because we can never demonstrate that what caused the autism is no longer present, especially if it's genetic in nature. We obviously, we're not at the level of technology where we can do anything like gene therapy. We can, however, provide treatment that can dramatically improve the quality of living for these individuals. And that treatment is largely based on the science of applied behavior analysis, which currently enjoys the most support in the scientific literature. That support actually includes an endorsement from the United States Surgeon General, David Satcher, And also it's supported by the largest review of the literature to date, which is the National Standards Project, which just completed its second phase that was published by the National Autism Center. Behavior analysts also work in collaboration with other professionals such as speech pathologists, occupational therapists, and physical therapists to provide the best outcomes. And this multidisciplinary approach is the one that we at ALC endorse wholeheartedly, down to our name in Autism Learning Collaborative. We very much appreciate and push for this collaboration between multiple disciplines of service providers to treat the whole individual and also the whole family. Although in addition to applied behavior analysis therapy and speech and occupational and physical therapy, which all enjoy scientific support, there may be other forms of treatment that can benefit individuals with autism in some ways, but it's important to maintain a healthy degree of skepticism about new and emerging treatments, because unfortunately autism has and continues to be a target for fads and pseudoscientific treatments that you may have seen online or TV. For certain, there are other things that you can do to support individuals with autism, but we hope that you will maintain that healthy degree of skepticism and check with professionals on whether a specific treatment is recommended for your child. I'm going to pass it over to my colleague, Sydney.
Okay, so what is ABA? Applied behavior analysis is an applied science. Everything that we do is data-based, it's data-driven. So that's kind of where that analysis part comes in. It's where we focus on the environment and behavioral interactions as they kind of go together. So we look at things that are happening around the environment and then tie those into different behavioral patterns that we're seeing. We like to analyze antecedents, behaviors, and consequences as they occur together. ABA is the foundation of therapies that has helped to get people out of institutions and live dramatically improved lives. This is kind of linked to some of those skills that we work on, and we'll kind of get into that. But some of that, daily living skills, independent living skills, different kinds of things like that. So the ABA approach. ABA strives to understand the unique ways individuals learn. So kind of one of the quotes that I really like to go by is if they can't learn the way we teach, then we need to teach the way they learn. So really kind of analyzing their environment and the best ways that they learn. So that might not be, sitting at a table and sitting in a chair and learning. It might be learning on the floor. It might be following them in their environment, using those natural opportunities to really kind of hone in and capitalize on those teaching opportunities. Behavior analysts conduct individualized assessments to learn about each child, and then we design that treatment plan that supports their unique styles and learning needs. So we take that initial treatment plan, and that's what we use for, parent goals, independent living skills, social skills. We follow these goals that we have chosen to kind of identify and work on. Some of those splinter type skills. So what does ABA target? It targets a lot of different things. This is just a very small list of some of the things that you can target. So we work on things like language and communication, play and leisure skills, social skills, motor skills. We look at gross motor and fine motor skills. This is kind of where some of those OT type programs come in, and we collaborate with some of those OT specialists to help with some of those motor skills. Daily living skills, vocational skills, so getting them job ready for when they do become young adults. And then sometimes pre-academic skills such as, staying on task, following directions, keeping themselves kind of on task with the rest of, what the class is doing, or group skills, things like that. We also work on behavioral challenges. So reducing and or teaching functional placement replacements for any behavior that represents as a significant barrier to learning. So we like to take those challenging behaviors, anything that might interfere with learning or functioning, And then we give them those replacement behaviors that can serve the same function, but allow them to be able to, learn from their environment, complete those functional independent living skills, things like that. And then we also focus on parent and family training. So ABA is a really important, or I guess family is really important when we look at ABA strategies, because once our therapists or our specialists leave the home, it's the families that continue on with that quality of care. So we really make sure that we target those families and make sure that we're able to provide some of that support to their parents and caregivers, just so that we make sure that things are the same across many different settings, many different people, and we're able to really teach those generalizations of skills. And we just want to make sure that their whole kind of everyone involved is in support of the things that we are doing and the things that we are teaching. So the process of ABA, you receive a diagnosis, and now what? So you have a formal diagnosis. That's when we will typically meet with caregivers and perform a initial consultation with them. We want to make sure that we fit along with the family and make sure that the things that we work on are things that the family is requesting. We will work on checking your benefits. So ABA is covered by, let me back up. So insurance typically covers ABA services. And so that's when we will get with the insurance companies and make sure that it is a covered benefit and get all that information out to the families. Then we will go and request for an pre-authorization through the insurance company. So we perform an initial assessment to kind of assess where those skills and those deficits are before we actually start working one-on-one with the child and their family. So after we conduct that initial assessment, that's when we develop that treatment plan that has, the goals, concerns, different kinds of things like that. How our plan on including the family and other caregivers, that all goes into that treatment plan. Then after we get approval from insurance companies for that treatment plan, then that's when we start looking at services and scheduling out the child with a one-on-one therapist. Typically it's every 6 months for insurance companies that we have to report back to them. We send them, our graphs, our data, our goals, show the progress or lack thereof that needs to be continued with ABA services. This is where we'll put all of those behavioral deficits. So, things that we're seeing that, continuation of care is needed to address some more of those behavioral skills or things that come up during that first 6 months of therapy. So course of treatment. We look at kind of 3 different things here. We've looked at intensity, frequency, and duration. So intensity, depending on the client, depending on their skill level, their deficits, and their age, this is where we kind of decide how comprehensive we need to be here. Depending on the age of the client and the skills, you might start ABA therapy for 15 hours a week, or, say you have a young kid come in who's really struggling with behavioral deficits and things like that. We might work on, requesting 40 hours a week of therapy. So it kind of depends on what's identified in the consultation and then what is identified in the assessment. So frequency, again, depending on their needs, their sessions can be scheduled anywhere between 10 to 40 hours a week. And it's typically 2 to 8 hours per day. So we try to make it as consistent as possible. So if they are being seen 10 hours a week, we might request to see them 2 hours a day at the same time of the day, so that we can make sure that we work on those skills that need to be addressed at a certain part of the day. And then duration. So continuation again is evaluated every 6 months until all goals are met and no additional goals are identified. So usually, again, every 6 months, if we find a new deficit or a new skill that needs to be taught, then we add those to those goals and then get reevaluated for the next 6 months. So goals are constantly changing and they're constantly evolving as we see the need for treatment.
Hi, everyone. Thank you so much for having us. I am Angela. I'm the CEO of Autism Learning Collaborative. I want to touch on some of the services that we provide specifically. We provide ABA therapy services for individuals with autism, 18 months to 21 years of age, in-home, in centers, as well as via telehealth. Our branches are located in Dallas and San Antonio, Texas, Albuquerque, New Mexico, and Omaha, Nebraska. Our treatment plans are catered specifically to our clients' needs, and it depends on what they would like to accomplish during therapy. We do provide free consultations with one of our board-certified behavior analysts, and this is to assess whether or not ABA is a good fit for the family. We understand that it is an intensive service, and there might be a lot of questions, there might be a lot of variables at the time, which might make it unsuitable for the family at the current time to receive services. But we can definitely answer all of those questions during the consultation. Next slide, please. We understand that this year has been especially hard for a lot of our families and then also our community. We have established a lot of self-guided courses that are completely free of charge as well. As you can see, there is a link there. If you would like to enroll, please feel free to. Our topics include ABCs of behavior and functions of behavior, providing effective reinforcement and functional communication training. We also provide a lot of free in-person and virtual workshops to the community. So if you have any topic that you'd like us to touch on that is within our scope, we would be happy to do so. We do firmly believe in providing value to our communities, and that's how we can get our communities to best get to know us. Next slide. The other thing I want to touch on is we are affiliated with EAS, Early Autism Services. They are our sister company. They have 13 regions across the United States and also are present in India and Australia. So if you do require services in any of those regions, please let us know and we'd be happy to connect you. Thank you so much. Also, feel free to connect with us via Facebook. We also have Instagram, we have LinkedIn, and we have a Pinterest site as well.
Just wanted to thank all our guest speakers today. It's been wonderful information. We really appreciate your time, and I'm glad we got to cover all different aspects of children's mental health. So as far as questions, I know ALC was answering them as they were being asked in the chat. Are there any other questions that somebody might have? Please put it in the chat. I'm looking right now. Something that was put in chat, it says legislation approved for Medicaid to cover ABA in 2019, but didn't provide funding. This legislative session, they were providing funding. However, the proposed rates were ridiculously low. Providers couldn't sustain their business with those reimbursement rates, or the states need to really work on making services recommended to autistic and any individuals more accessible. So that's something that we really need to advocate for our parents and our children.
Yeah, Berna, if I could just pop in here. We actually had a rate schedule hearing on March 16th, which is what that comment was referring to. The current rollout for Medicaid coverage of behavioral therapy for children with autism is scheduled for February of 2022. We are trying to advocate, and we suggest that anyone who is touched by autism spectrum disorders, either through their own family or others that they know, to advocate to their local representative to speed that up. We as an industry asked in a unified voice at that hearing for them to push that up to September 1st of this year. We don't know if they will listen to us. And then the other factor is the rates are about half of even the Medicaid rates that are available in our neighboring states. So we really want parity with our neighboring states with respect to the rates.
Thank you, Dr. Hurst. Let us know if there's anything that we can pass to our parents, children with autism, how they can advocate for their child. We'd like to pass it on to our children,
Verna,
our parents.
I'm seeing a question earlier on that there used to be this was for, I think, during Melissa's presentation, there used to be a 72-hour crisis training through Health and HHSC. I haven't been able to locate online. Where would one call for that program, or is it not available? That's from Gloria de la Garza.
Thank you, Jackie. Melissa, could you answer that?
I'm not 100% sure what you're talking about. We've done some crisis training in the community, but it's mostly focused on training law enforcement officers and school police officers. So I think you're talking about something else, but I'm happy to send you my email in the chat. And if you want to connect with me or my phone number, we can talk about it more and trying to figure it out.
Thank you, Melissa. Any other questions?
I'm seeing a question from Jane. Is there an opportunity to enhance care by reclassifying the autism spectrum from a neurological, from a neurodevelopmental disorder to a neurological disorder?
I'm not sure exactly how that would change things. It might, so I can't really answer the question directly. What we do know is that the CDC, the federal government, and most state governments have identified applied behavior analysis therapy as medically necessary. So it has already reached the standing of medical necessity. Really our biggest barriers are just the funding and the very fine balance between our ability to stay in business as a company and pay our staff to minimize their turnover. And it's a very difficult job, as I'm sure those of you who work with individuals with mental illness know. It can be heart-wrenching. It can be a very difficult job to keep your morale up. And really just the rates that even commercial insurance pay make it very difficult to, to financially support the services that we provide. Those are the main barriers, I think. Aside from just, the state of Texas, as much as I love Texas, dragging their feet with helping low-income families afford our services.
Thank you, Dr. Hurst. Something was just put in chat. Another option, sorry about that. Another option for attendees, if you have a young person, 13 to 18, who would like to engage in the youth council, have them email me and it has Rebecca Hildebrandt's contact information. So please do so. It's such a great program that they've started, and that feel like this is a program where we're being proactive instead of reactive. And so that's great to see. Thank you, Rebecca. Any other questions? Okay.
Yeah, I just posted a question just for clarification. Are the organizations sharing today, are they nonprofits?
The Center for Young Minds is a part of the Ecumenical Center, and we are a nonprofit.
Thank you.
Okay, Gloria just answered about the 72-hour crisis training. That was through ACOG.
So this is the state required that all law enforcement officers participate in a 72-hour crisis intervention training. But here in Bexar County, it was decided to expand that to a full 40-hour training. And so you have that for both focused on primarily adult behavioral health issues and children behavioral health issues. So the 72-hour training still exists. It's not something though you can do online. It still has to be in person.
Thank you, Dr. Van Schultz. Any other questions? We have some time for some more questions. Anybody have any other questions?
Who is qualified for the AACLG training? Do you have to be in law enforcement or some type of first responders?
For the ACOG training, that was law enforcement. I see that the question is if there was a home-based training for caregivers. I am also not familiar with the 72-hour crisis training for caregivers other than the mental health first aid that I have seen, but that's not a 72-hour course.
Right. So you can learn more about the ACOG Crisis Intervention Training through Academy at aacog.com. Gloria just put in here, Melissa, about maybe associated with the yes waiver. Gloria, what were you saying would be associated with the yes waiver?
I think they're talking about the caregiver training. And so there are some trainings from ACOG that do help caregivers. I don't know that it's not necessarily connected to the YES program, but we may have had individuals in YES that we referred over for those services or for that training at ACOG.
Great, thank you, Melissa. Any comments on today's presentation from anyone? I hope that y'all got a lot out of this. We had a variety of things to talk about, so I'm still reading in chat here.
Vern, I believe some people are asking whether about the slide availability after the presentation.
I know we're going to have it. This has been recorded and it's going to be on our website. The recording will be. I know several people asked for the slides. Go ahead and put it in chat which ones you're interested in, and then let the presenters say yay or nay.
We give full authority for our slides to be shared.
Thank you, Rebecca.
Same for juvenile probation.
Thank you, Jeannie.
That's not a problem at all.
Feel free to share our slides.
Okay. So can we have the next slide? Just want to let everybody know that our next general meeting will be June the 8th. And it's going to be, the theme is going to be Men's Mental Health Awareness Month. So we're looking forward to that. Next slide. We're also going to have some fun. Jeannie Swatzel is going to lead us through some Zen Tangles on June the 16th from 1 to 2:30. Please spread the word. It's very great mindfulness exercise and very helpful if you like to do creative stuff. So we're going to have that presentation and tell others about it so they can come join us and have fun. Next slide. Doug?
Well, if next month is Men's Mental Health Month, sounds like I better listen in. I'm looking forward to it. I want to thank all the presenters today who were on the call. I want to thank Jeannie and Melissa and Rebecca and Dr. Hurst and Sydney and Angela. This was an outstanding presentation workshop today, really excellent. And I think one of the things that comes across to me is, and I know Jeannie and Melissa and Rebecca in particular can think back over the last 5, 6, 7 years. And, you know, the level of interest and support in our community just keeps going up. And a thing I keep thinking about is the opportunities we have for collaboration. There's so much need. If each of us know where our strengths are, we can work better together. I think there's a theme there someplace, better together. So this has been a great workshop, wonderful attendance today. And thank you everybody for both presenting and for tuning in. And we'll look forward to next month. And thank you to the NAMI staff for putting this together.
Next slide. I would like to thank our planning committee. They've been working hard to have some great presentations. And Lori has been calling and it's keeping our attendance up. So we really appreciate that. But I appreciate everybody that's on the team doing a great job, and we appreciate you. Thank you, everyone.
Berna, real quick, this is CJ Van Green. Sorry, I just tried to post the movie screening. I thought to segue after, as we're leaving this fantastic presentation on children and awareness, the Amazon Logistics DSX-7 team has sponsored a small donation for movie screenings. And right now there is a small film called Unstuck, an OCD kids movie. And anybody is, free to attend. There, it's via Eventbrite, and the information can be found on our website. But I was trying to get the link submitted out here for you all. But reach out to NAMI at NAMI, and I'd be happy to redirect you if you've missed it. But that is out there for your viewing pleasure.
Thank you, CJ. And thanks for getting the screening all together. I think our members are going to enjoy that.
It's really good. It's only 22 minutes, so it's a quick view, but very interesting perspective from 6 children, and how the clarity they have in describing the way they felt and the struggles they had. It's pretty impressive, pretty empowering.
And CJ, I want to thank you for getting the newsletter out each month, and then getting the recording on our website. So if anybody wants to go back, you can go on our website and find out what months we had what, and go in and listen to our general meeting. So please pass the word. Thank you, everybody.